Welcome everybody to this second session of day two. We have a great session on an area of very keen interest for interventional cardiologists and non-interventionalists alike, mechanical circulatory support. Have a great panel of friends, colleagues, and super experts in this field. Kendra Grubb from Emory, we have Holger Thiel, and then also Nicholas Van Meegen. We have 3 talks followed by live cases, and just to start, I'd like to introduce a poll question for all of you. We'll post the results of this poll at the end of the session. The poll title is "Every cath lab should be able to install mechanical circulatory support other than balloon pumps. Yes or no?" We'd love to get your feedback and interest in that regard. As with the prior sessions, there's a chat feature, so please send in questions, comments via the chat, and they'll be responded to in real time. Let's start first with a presentation by Nicholas on large bore access management, a tutorial really practical for those who wish to employ mechanical circulatory support.
Thank you very much, RJ. So I think this is a very timely topic. As you mentioned, interventional cardiology is quite interested in this space of mechanical circulatory support, but we all need to acknowledge that at this day and age, we still require large bore access to use these mechanical cardiac support systems. So basically, you can completely negate your benefits with these MCS devices when you end up with access site management. So I think a tutorial on large bore access makes a lot of sense. And the basic principle is garbage in, garbage out. If you get in trouble with your puncture, probably your closure also is jeopardized. So basically you have to put your attention there and have a comprehensive and meticulous approach from the start of your access. I will not cover procedural planning, but if you have the opportunity, do procedural planning with CT scanning, because it gives you a multiplanar reconstruction of your arteriotomy site, and you will not get into the major surprises, because oftentimes access site complications come because of the unknown. But often, on the other hand, in cardiogenic shock, for instance, you will not have the luxury of having these CT scans, and then I think you will have to rely on your skills of getting access and confirming that your access is appropriate to accommodate large bore devices. So in terms of access, I will focus on ultrasound guided access, and then we will switch gears to closure, and then predominantly on percutaneous suture or plug-based closure. So ultrasound guidance, I think, is mandatory for large bore arteriotomies. I think it's a mistake not to rely on ultrasound guidance. And what you need to get used to are these basic views. You need to be able to identify the long axis view to appreciate the bifurcation, and then you need to be able to rotate into a short axis view where you eventually will identify the superficial and profunda or deep laying femoral arteries, and then as they collide, you enter in the common femoral and you approach your target site for your arteriotomy. On the right hand side you see a Mickey Mouse kind of appearance that illustrates where the deep and superficial part of the venous system come together, and on the left hand side you see the superficial femoral artery, and if you move further upwards north you will then see the femoral bifurcation. There is some variation there, the anatomies can vary, but this Mickey Mouse sign pops up on a regular basis. So first what you do with your ultrasound, you identify the femoral bifurcation. And you can see here how we do that. We have the short axis view. You see the superficial femoral artery on top, the profunda below, and as you move your probe more cranial, you will you will fall into the common femoral artery. If you then move further on, you will see a major branch coming off this common femoral artery, and that is the epigastric artery. That marks the beginning of the external iliac and identifies also the retroperitoneal space. So this is an important landmark that you need to be able to identify with ultrasound. So here you see a color of the same image on the left-hand side without color. So we started at 9 o'clock, 9 or 10 o'clock with the epigastric artery, and then we move south towards the bifurcation. So here at 10 o'clock, that was the epigastric artery, and now we move the probe caudally. We are in the common femoral artery, and as we move further, we enter the bifurcation, and here you see the profunda below and the superficial artery on top. And then also, as you are getting access, ultrasound will help you assess your access entry and make sure that you will avoid calcium when you puncture the artery, and you also remain in the middle of the vessel. And here we are puncturing the vein, same thing, you have the needle tenting that will help you confirm where you enter the vessel. I think what we have seen the last couple of years is that also in terms of access management, you can proceed to a more lean procedure. On the left-hand side, we leverage the sheath of the Impella CP to introduce a 7 French guiding catheter. So you have only one puncture, and you use the sheath of the Impella CP to also introduce your guiding catheter for your coronary intervention. On the right-hand side, you see a lean TAVI approach where the common femoral artery is being used for the large bore access and the superficial femoral artery for a 6 French that will then accommodate the pigtail catheter. So basically, it's a single limb procedure. Percutaneous closure. We have suture and plug-based closure, but suture-based closure can fail, of course, and I think the best data that we have dates back from 2015, the multi-center control registry, where they had access site complications in 20% of the procedures. They were comparing ProStar and ProGlide. Basically, you have to be an expert in either one of the two, but in both, at least in those series, the access complication rates were as high as 20%. And that doesn't come as a surprise, because these are the sheets that we encounter when we withdraw the sheet from the patient. They are really beaten up from times, and you can already appreciate the rugged, rough surfaces and also the sharp edges that may also damage your arteriotomy itself. They can lacerate the vessel, and it may help explain why even in a perfect situation with perfect skills and techniques, you still can have access site complications using suture or plug-based closure. I think it's also important from the multi-center registry that stenting was required, bailouts covered stenting in almost 5% of the cases, and urgent vascular surgery in almost 3% of the cases. Now switch to MANTA. MANTA is a plug-based closure, and this is the data from our first 500 patients in Erasmus, where we managed to do a follow-up angio immediately after the closure. In almost all the cases. In 3% of the cases, we were not able to do a final angiogram after MANTA closure, but in the remainder, we had an angio, and that taught us a lot. In 16% of those cases, we had an incomplete closure. Either there was no hemostasis or there was an occlusion. And in the majority of the cases, we were able to solve these issues with a bailout technique. Either it was prolonged manual compression or balloon occlusion, prolonged balloon occlusion, but we also needed vascular surgery and covered stenting in a minority of those procedures. Eventually, we ended up with an access site complication in 8% of our MANTA closures. That was our first 500. We are now beyond 1,000, and I must say that our access complications have only gone down. Why? Because we looked further into the prospective studies. And we recently published a meta-analysis, a patient-level meta-analysis that generated quite some interesting findings. And one of the major findings, at least from my understanding, was this phenotype of patients who have a small caliber artery that is laying deep under the skin. So more obese patients with small arteries, those were the patients that had the most complications. And you can see that in the graph below. And then if we looked at what other interesting features, if a left femoral access was associated with more complications than a right femoral access, probably because you will only go left when there is advanced disease. So this is a selection bias. But also, and that is consistent with the literature, women have a higher likelihood of access site complications as compared to men. So I think we had a lot of ingredients to proceed with a randomized trial, and that was the MASH-TAVI randomized trial executed in Rotterdam and Toulouse. 210 patients were randomized to either MANTA closure or the use of 2 proglides. And in summary, there was no difference in the primary endpoint of access site complications between the 2 techniques. Numerically, we saw maybe a little bit more complications with MANTA, but that was not statistically significant. What was striking, however, was that the modified vascular closure device failure occurred double as much with the 2 proglides versus MANTA. And this closure device definition was any bailout that was required to achieve complete hemostasis. And that could be manual compression that exceeded 5 minutes, but also the use of additional closure devices or covered stenting or bailout surgery. Now, on the right-hand side, you see that with proglide failure, in the majority of cases, it required an additional proglide or angioseal. So you could leverage the safety wire to add another closure device. You don't have that luxury with a MANTA. In MANTA, the major, predominantly the bailout was prolonged manual compression, but sometimes covered stenting and bailout surgery were required, but in very small number of patients. So there were only 4 covered stents used in this trial in MASH, and only 2 patients required bailout surgery. But it's fair to say that the way these devices fail is somewhat different. With sutures, they can tear. Calcium is maybe not as appropriate for suture-based closure, where MANTA may have some issues with the collagen or the anchor that may or may not occlude the vessel or may result in incomplete closure with bleeding that may require vascular surgery and covered stenting, again, in a minority of cases. I think a takeaway from our latest experience is that we are all familiar with the optimal target for our access, which is in between the femoral bifurcation and the epigastric artery. So that is the common learning. But for a MANTA device, you need to be a little bit more secure, and you need to stay away from that distal bifurcation. So you need to stay away at least 2 centimeters away from the bifurcation to have a more secure MANTA closure. I think an important lesson learned from our extensive large bore experience is that this final angio after your closure device deployment gives you a lot of information, because sometimes you have hemostasis, but there is an occlusion. And if you did not do the final angiogram, you will only reveal that issue in the ICU or on the ward, and of course then the situation becomes more dramatic than as compared to having that immediate identification of the issue in the cath lab, where you have all your opportunities and bailouts at your disposal. So this is my final slide. So when would I select suture-based closure? When would I choose plug-based closure? Well, if there is protamine allowed, I think you can go for both ways. If you preferably would not want to use protamine, then maybe you want to opt for a suture-based closure. And what is the situation? For instance, if the patient was not preloaded with DAPT and had extensive stenting, and you don't want to use protamine to neutralize the heparin, yeah, then you may want to use sutures over MANTA. On the other hand, if there is heavily calcification, I would definitely opt for a plug-based closure. If the patient is morbidly obese, then my preference again would be suture-based closure. And as last remark, I would say in an ICU setting, when I'm not sure how long a patient would require mechanical circulatory support, I don't want to have this pre-closure indwelling for too long. Then MANTA would be my closure option, and then off-label, I would use ultrasound-guided closure with the MANTA system. With that, I'd like to thank you for your attention and open up for the discussion.
Really great overview, and I think you took us through the importance of doing safe access from the beginning, but then also managing the closure issues. And this is a critically important skill for interventionalists, because most interventionalists, I don't think, have the adequate peripheral training to be able to do these procedures in this way. And as you so rightly pointed out, if you're going to use MCS, if you negate the benefit of MCS by having a vascular complication, then we haven't helped the patient. And so it's really important to reduce the risk of these complications. Maybe I'll start with just a follow-on to the last part of the talk, and that is talk about the learning curve on these devices. Is it different? Is there a learning curve for each? Is there one that's easier to learn, suture-based versus plug-based for large bore access closure? Maybe first we can, I guess, start with Kendra, and then certainly we'll ask Nicholas for your opinion, and Holger as well.
So I think that they're equally easy to teach. We have a new group of fellows every July, and we're able to teach them both. I do think that they're more familiar with the Perclose device, and so that ends up being something that they gravitate to. You're not having the variability of the thickness of the skin. Sometimes there's subtle differences, especially in our heavier patients or obese patients, that make the MANTA more challenging, especially in the beginning. But one of the things that was key to his entire presentation is that all of it has to do with the initial stick.
Yeah, that's a great point. And maybe Holger, tell us, so, you know, what do we do with this patient in shock? You don't have iliac imaging. How do you proceed practically in that standpoint? Do you take a quick picture? Do you take pictures at the end? Or somebody who you're instituting support, but you don't have the luxury of being able to get all the pre-procedure imaging, such as a CT or an ultrasound or maybe even an angio?
It's a very good question. Difficult question on the other hand. So usually we try, in particular if it's a patient with acute coronary syndrome with an acute myocardial infarction, if you ask me, I would always try to go for the radial artery and try to perform the PCI via the radial approach, even in patient with cardiogenic shock. But in case I need mechanical circulatory support, for sure we have to go to the femoral artery. And in this case, I probably would use ultrasound-guided puncture. I will show it also in my presentation, and probably this is very important also to avoid any complications. So this is maybe also one of the reasons why all the mechanical circulatory support devices currently have not shown to improve survival. This is probably extremely important that we address these complications, and that's the reason why the presentation by Niklas was so important, because we have to learn on this and we have to really avoid additional bleeding complications and also ischemic limb complications in these patients getting a mechanical circulatory support device.
Yeah, really, really important point there as well. And Nicholas, to you, you only started talking a little bit at the end about this delayed closure issue and closure in the ICU. So talk us through that a little bit. What's preferred in patients that have had support in for a long time? Do you just sort of say, fellow, hold for a really long time, or are there better ways of doing it than that?
Yeah. I must say that there's still also the option of surgical closure, of course. I would not ask the fellow to stay and hold manual compression for 30 minutes or longer. We typically use either sutures or plug-based MANTA closure for mechanical support closure in the ICU. If I can anticipate that the support time will be within 72 hours, there is the option of a pre-closure, and then we install the pre-closure before the large bore catheter goes in, and then we wrap them in sterile gases, and you know, 2 days later we can close the artery, closing the pre-closure. But if it's an unknown, then I would really rely on MANTA. And of course, we are all familiar, or you may be familiar with MANTA, that you need to determine the arteriotomy depth with this depth measurement tool. And you don't have that in an acute shock setting often. That said, there might also be some hematoma around the puncture site and so on, so it might modify the arteriotomy depth. So this is why I would rely on ultrasound-guided MANTA closure, where I use my left hand to hold a linear probe, and then using this ultrasound technique, you can see the anchor approach the arteriotomy, and you can even see it getting locked at the arteriotomy site on the inside. And this is then where I confirm that I can safely advance the collagen on the vessel and sandwich basically the arteriotomy between the anchor and the collagen. So I think this ultrasound technique is not being marketed at this point in time. I think it is still off-label in the United States, but it is definitely a technique that may help you get safe closure in an ICU long after you got large bore arteriotomy access.
That's really interesting, because I do think that for the high-risk patients, high-risk groins, oftentimes those patients are being brought back to cath labs to, you know, have things under direct visualization, and so any ability to potentially do it upstairs would be of use, provided that the data supports it in that way. Well, Nicholas, I'm going to let you go to set up the live case. Good luck. We look forward to seeing you at that time. And Holger, again, we're going to introduce your topic, which is going to be essential principles of commercially available mechanical circulatory support.
Yeah, Ajay, dear colleagues, it's a pleasure now to present the essential principles of commercially available mechanical circulatory support. And we just heard about how important it is that we address, in particular, the possible complications of large bore access. These are my disclosures, as you can hopefully see in a second. Unfortunately, it's not advancing my slides. Can we solve this technical problem? Or maybe the technicians can advance my slides. It's not doing anything, sorry. Trying once again to advance the slides, but it's not.
Sure, we have a little bit of a, there we go.
Okay, no, okay, now we have advanced more than 10 slides, and maybe can go back, sorry. Can you go back to the first slide, sorry? Oh, go further on, so that we just start with the first slide. Can you go back? Okay, I do it on my own, sorry. Okay. Sorry for this technical problem. All right. Can we start now?
Come back and they're going to try to resolve the problems. You know, I guess in anticipation of your talk, Holger, you know, one of the things that comes up is, should labs have access to all of these techniques? And I'm sure we're going to get to what folks say during the poll. But maybe just as a general principle, what do you think labs should focus on? Should they focus on doing one thing well, or are there specific skills that are transferable across device platforms that then allow them easily to get access and utility of the other devices?
So if you ask me, probably the technique is similar to all the for all the devices we are currently using, for Impeller, maybe also for the IVAC 2L, which we will see in a few seconds, and also in the live case presented by Nicolas. And it's also extremely important for ECMO. So the access is always the same. And probably also the techniques we are using for the closure of the large bore access are also probably very similar for all the different devices. Nevertheless, the devices are totally different. That's that's important for us to understand. And if you ask me, a tertiary care center dealing with all kinds of cardiogenic shock and severe cardiogenic shocks, they should for sure have available at least 2 or maybe 3 devices. But for the maybe primary or secondary care centers, probably it's not required to have all the different devices available. I'm not sure if the technical problem has been solved now.
The technical problem? Yeah, so let's go back to your slides, Holger. And Kendra, I'm going to come to you first after the talk to get your opinion on this. So let's go to Holger's slides.
Okay. All right, so once again, I will try to start with my presentation. And you can see these are the different available devices we currently have. We have the intra-aortic balloon pump, which has 7 to 8 French femoral artery access. It has no left ventricular unloading, or maybe some, but this is currently not well defined. And I will show you, in particular, the intra-aortic balloon pump, because it's still used, in particular, AJ in the United States. Still 30% of all the devices are currently mechanical circulatory support device. And you all know that diastolic augmentation leads to an increase in blood pressure during diastole, whereas at systole we have a further decrease of the blood pressure. And this leads theoretically to afterload reduction and a reduction in myocardial oxygen consumption. Very old publication, but look for this. This is very interesting. 78 patients, registry, pre versus post intra-aortic balloon pump, no difference in heart rate. Systolic blood pressure goes down, diastolic blood pressure goes up, but the mean blood pressure remains the same. And the cardiac output goes up by 0.5 liters per minute. But if you do this in a randomized fashion, as I will show you in the next slide, if you do this in a randomized fashion, then you will see that the cardiac index also goes up in patients with control. This is from the IVP Shock 1 trial, which showed that the cardiac index goes up in both groups, and there's no difference at all between the intra-aortic balloon pump and the control group. So the intra-aortic balloon pump, if you ask me, has really no benefit at all on cardiac index or on the cardiac output. That's the reason why in current guidelines, the intra-aortic balloon pump is not recommended anymore. And in particular for high-risk patients, it's also not mentioned. So this is a class 3B recommendation for the use, at least in Europe, for patients with cardiogenic shock. Now coming to the more advanced active devices, in particular the Impeller. We currently have the 2.5, 3.5 or CP, the 5.0, and as well as the 5.5 long duration, which we have. And as you can see it here, that has a maximum flow of 51 RPM. The access size for the cannula is usually between 12 to 14 French. We use the femoral artery, and it has a significant effect on left ventricular unloading. These are the different sheaths you get, and you will see it in our live case demonstration. For the CP, it's 14 French. For the 2.5, it's 13 French. And you have a peel-away sheath. And afterwards, if you leave the device in place, it's only 9 French, finally. This is how it is usually done. You can see it here, the advancement of the device, and in the next video you see the advancement over the aortic valve, and this is how it is placed, and you have usually a pictal catheter at the front to avoid any sucking from the LV, which makes it easier. This is what we also do now in our live case presentation. So we use the one-stitch approach. You have with the peel away sheath 14 French, and you can advance. Also, there's a lot of friction in 9 French, the impeller, as well as a 7 French sheath, and also a 7 French guiding catheter. So this is possible to be done. We will show it in our live case demonstration. This is what we have heard just a few minutes ago by Nicolas. You have to consider already in advance, and particularly if you're doing an elective high-risk PCI, to use large bore closure options. But you have heard about all these different devices before. And this is how we will do it in our patients. We will use the ProGlide system for closure of the large bore access after the intervention. So now we have the Impeller CP Smart Assist, which is able to provide up to 4.3 liters. As you can see, the cannula size is still the same, and it now has a fiber optic pressure sensor. And this allows also a little bit better left ventricular and diastolic pressure assessment. This is what I mentioned before. So far in cardiogenic shock, we have several randomized trials. Nevertheless, only few patients, 150 patients altogether. That's the reason why there's no difference maybe in all-cause mortality. We have an increase in mean arterial blood pressure, a decrease in lactate, but as you can see here, more bleeding, and a strong trend towards more limb ischemia. And that's the reason why we have to address, in particular, these complications or these possible complications for these patients. Few words on tandem heart. I only brought 2 slides. This is from a very old publication from our group where we did 21 patients. As you can see here, that's a transeptal puncture and the dilatation of the septum. And by this, you put in a large bore cannula into the left atrium, and you suck blood from the left atrium, which is, by this centrifugal pump, returned to the lower abdominal aorta, and this provides up to 4.5 liters per minute. And this is how the system looks like. The console has become much smaller in comparison to our publication in 2001. And next slide, you will see. All right, yeah, the next slide, you will see the IVEC 2L. I also only brought 2 slides on this because you will see it in the live case presentation by Nicolas. This is the way it works. You connect this to a console from the intra-aortic balloon pump, and you can have a pulsatile flow up to 2 liters. You place this into the left ventricle, and you are able now to remove the blood from the left ventricle to the aorta. A few slides on ECMO. You will see in the next few slides. If the slides advance. All right, just skip this for the sake of time. Now a few slides on ECMO. For ECMO, usually you use 18 French arterial cannula, a 22 French venous cannula into the right atrium. You have a centrifugal pump, an oxygenator, and a heater, and this system is able to provide up to 7 liters per minute, depending on the cannula sizes. For removal, very important for you to see, this is how we do it. That's a so-called Sulimov technique, and Dimitri Sulimov will be the primary operator for the case we do. Usually we have an antegrade cannula and a retrograde cannula, and between this you have a dead space. And we have a new technique for removal. So we put in a Swan-Ganz catheter into the common iliac artery. We put in a blood pressure cuff here, and by this we have no flow here, and then we flush it with saline, and by this we are able to remove usually large thrombi from the dead space. And this is how we do it nowadays. This is how it looks like afterwards, and we usually use 2 ProGlide for this, and you can see it here also once again with ultrasound that there's really no pseudoaneurysm and also no fistula, and this is how we do it. Important, if you are considering ECMO, you have to consider to use also maybe the additional use of an intra-aortic balloon pump or maybe an impeller to provide a better pressure volume curve for these patients. This is important if you are doing it because you have to avoid this, a fully thrombosed left ventricle. This is a meta-analysis based on observational data, which showed by venting a possible mortality benefit. And a more recent publication you will see in the next slide. These are other options. And the next slide you see venting with impeller led to a reduction in mortality in this propensity matched analysis. Currently, we do the ECL shock trial where we randomize patients to ECMO versus standard of care in patients with severe cardiogenic shock. And hopefully, we will be able to show more evidence in addition to early revascularization, culprit lesion only strategy, maybe norepinephrine, as you can see it here for mechanical circulatory support or for intra-aortic balloon pump. We currently have no evidence that they can reduce mortality. And as you can see it here, currently our ECL shock trial has now randomized roughly 200 patients. There's another European trial which has now randomized roughly 20 patients, and the danger shock trial, the trial with impeller CP versus standard of care, currently has randomized a little bit more than 210 patients. So within the next 1 to 2 years, hopefully we will have more data on how to proceed with these patients and maybe better to identify patients who really have a benefit with respect to mortality from mechanical circulatory support. Thank you very much for your attention.
Well, thanks so much, Holger, especially for overcoming the technical difficulties, which are similar to sometimes the MCS cases, but you persevered and we got it done, so that was great. Maybe, Kendra, I'll start with you. Just in terms of, you can do everything. You can do ECMO, you can do balloon pumps, you can do impellers. How do you sort out which patient needs what, and is it a dynamic process? Just take us through your thinking. I know you can get into the weeds here, but as a general principle, how do you look at what a patient needs?
I think it starts with how much support they need. And so, if a patient just needs a little unloading, then there's room for a balloon pump. If they need complete support with unloading of the ventricle, just like he just was demonstrating, that's going to be ECMO with an impeller. And so it's really geared towards what the patient needs.
Yeah, I think that the individualization is where people really need to sort of think and make the diagnosis, which can change over time as well. Holger, you just briefly mentioned, this venting issue. What are you using for venting at present? Does it depend on the presentation or the syndrome itself? And is there still a role for balloon pumps in those circumstances?
Yeah, as I've shown to you, the meta-analysis by Russell and colleagues, at least for the intra-aortic balloon pump, in this meta-analysis, there was a reduction in mortality. But if you ask me, so formally, I have been a believer in the intra-aortic balloon pump, as you may know, but we have done the randomized trial, and honestly, just by shifting the diastolic to or the systolic blood pressure to the diastolic blood pressure, I'm not sure if this really is able to do sufficient venting for these patients. That's the reason why we usually use an impeller, or maybe, which is much cheaper, which is also a nice option, is using a 7 French pictal catheter, which is connected to the venous cannula. And by this, you also are able to suck blood from the left ventricle, and this helps also in venting of the left ventricle during ECMO use. But nevertheless, you will not always need venting in these patients, so you should always look if there is enlargement of the left ventricle, if there is maybe some stasis in the left ventricle, and if there is no opening of the aortic valve is not seen in the in echo. And also, if you have a flat line in the arterial blood pressure during treatment on the ICU, then you should consider venting. And that's the reason why, personally, I'm clearly in favor of it, but you will not need it in every patient.
Yeah, I think that pulsatility tracing can be very, very useful. And because of your penchant for randomized trials, maybe you're going to do a trial with the 7 French pigtail. That would be interesting. Kendra, one last final question for you. For STEMI complications, like a pap muscle rupture, VSD, any specific devices that are preferred, or just get them on support and then do what needs to be done after that time?
I think that the latter is probably the case. Get them on support, figure out where you are, what additional steps you need. We like to wait as long as possible to address the VSD if we're going to surgically. And so if we can unload the ventricle and stabilize the patient, have end organ perfusion, that's our primary goal. That allows us time for the tissues to recover somewhat before we do any type of surgical intervention. And so again, getting back to what the patient needs, but the more support, the better.
Yeah, and I think that in terms of wrapping this up, the importance of Nicholas's talk is really germane too, because escalating levels of support incur escalating bleeding risk too. And so the better you can do to prevent the bleeding, then you're going to maximize the benefit of the procedure and minimize the risk. So with that, Holger, we're going to let you go off to the live case, and I'll just present on RV MCS, when and how. All right, so we heard about large bore access, we heard about the variety of types of left-sided support, and I'm going to talk a little bit about right-sided support. It's sometimes neglected and sometimes forgotten, but really important for some of these critically ill patients. Now, the reason it's neglected and forgotten is this is somewhat of a historical paper looking at causes of cardiogenic shock. Remember, we don't get called often for diagnosed patients, we get called for a sick patient. And what that means is we as physicians have to actually make the clinical diagnosis of what's going on with the patient. And too often, I think, as interventionalists, we're just conditioned to the acute MI cardiogenic shock, the LV is the problem, and that's because, as you see here on the slide, the most predominant cause of cardiogenic shock is LV failure. But just as any good doctor will tell you, you have to think about valvular complications, you have to think about sepsis, it might not even be LV failure, and similarly, you need to think about the right ventricle as well and not just forget about it, because the default to just put in a left-sided support device, whether that's an Impella or a balloon pump, will sometimes be great, but oftentimes, if the diagnosis is different, may actually hurt the patient in that specific scenario. So when we look at the right ventricle specifically, it's important to recognize that RV failure, no matter what syndrome you're talking about, increases mortality. In combined failure, in failure with pulmonary hypertension, in PE, whatever it is, COVID, RV failure is a bad thing. And generally, we don't see it that often because the RV tends to be pretty resilient. But when we see it, these patients are very sick and they need to be supported. Interestingly, one feature of the RV is that it's actually quite resilient in the sense that it can recover. And so this is this data from infarction where one can see there's an upfront mortality risk, but if you can ride out that initial phase, the patients tend to do better, and that's in contradistinction to LV failure, where once you start getting severe LV failure that's irreversible, patients will have a bad prognosis. This is what makes the RV ideal for solutions like temporary percutaneous support, because if you can ride out that initial insult, patients may often recover after that time. This is a slide similar to what Holger showed. It's from Naveen Kapoor, demonstrating what most people know very well up on the top is LV support, but what people don't know as well is types of RV support, and whether that's Impella RP, VA ECMO, tandem configurations, and that's what I'll be focusing a little bit on today. ECMO circuits, well known. There's VA ECMO, there's VV ECMO. ECMO does unload the right side of the heart by basically decompressing the right side, injecting the blood back on the left side. That is a form of RV support. If you run it with an oxygenator, as is a typical ECMO configuration, you also get support for the lungs if the lungs are not oxygenating well. Standalone VV ECMO typically is not going to provide RV support. It can provide oxygenation, but won't give you support of the RV. Now, how do you actually put this in place? You can use conventional cannulas, but there are also specific cannulas like the Protect Duo, which are designed to basically take blood from the right atrium / SVC and inject it into the PA, thereby bypassing the RV and providing RV support. The nice thing about this specific cannula is it's designed for IJ access, and so patients can be ambulatory or sitting up with this in place, and it's sutured in place and provides good levels of support. This is sort of the ambulatory Protect Duo configuration where you sort of have this tandem pump. These are big cannulas, they're not small cannulas, and when they're placed, patients will get adequate RV support in that way. You can hook up an oxygenator to it as well. The Impella RP is an RV support device for femoral venous access. It has this 3D shape that allows you to sort of get through most configurations of the RA and RV and across the tricuspid valve. It's 22 French motor, and it can provide flows of up to 4 liters per minute. Patients do need to be anticoagulated, and they have a venous sheet that stays in place during that time. The data on this, predominantly from Recover Right early on, show you that you immediately improve cardiac index and you lower CVP. That's what you're trying to do. In fact, when you want to diagnose RV failure, what you really need to do, besides looking at the echo, which can show a blown RV, is you want a swan demonstrating you have a high CVP, typically low PA pressures because the RV is not generating any force whatsoever. This is a study that we had published with the early experience of Impella RP, both in post-cardiotomy shock as well as post-LVAD. And what you also see in addition to this augmentation of RV performance indices is a decline in the pressure requirement that happens relatively rapidly with an average duration of support in this study of approximately 4 days. Now, in addition to this, let me just advance this slide here, we also, from our experience, showed something that was non-randomized, but in a comparative fashion, that the support that you could get and the outcomes related to the support that you could get from supporting the right ventricle with percutaneous support was similar to that with a surgical RVAD, and these are for post-LVAD types of patients. And so one can appreciate that if it's done percutaneously, less invasively, there's going to be less bleeding complications, and if the outcomes are good, we can see why you might gravitate towards using percutaneous support first rather than going back to the OR for a surgical BiVAD if you think that the insult will be somewhat transient. And so that's an important facet of this. Now, in terms of in the use of acute MI, which is more in the wheelhouse of interventional cardiologists, I'll show you a quick case. This is a patient who presented with a rip-roaring inferior MI, had actually a cardiac arrest, was resuscitated. Patient was taken for emergency PCI. This is what the right looks like. It was occluded. The LV-gram showed an inferior MI. And interestingly, the left side was basically benign. There was not significant disease on the left side. If we look at the initial hemodynamics, this was diagnosed with a right heart cath pre-PCI. This is not standard of care in many centers, but we believe for shock patients it ought to be because you can diagnose what exactly is going on with the patient. The patient's clearly in shock with an index of 1.2 on dopamine. We know this is cardiogenic shock, but right now there's no clear evidence that this is LV. So if you put in a balloon pump or you put in an Impella in this type of patient, it's not going to help the patient because the patient needs reperfusion in support of the right ventricle. And so that's a very, very important principle because oftentimes you see people just defaulting to what they're used to, and that would not help this patient. So in this particular case, reperfusion was achieved by direct stenting, good flow distally, and the right heart cath was left in. Notably, after the PCI, the pressures improved somewhat. This was predominantly through reperfusion, and the PA sat went up to about 60. So therefore, on only 8 of dopamine, this patient could be managed, and perhaps you want to wait in the cath lab to see if anything changed for about an hour or so. But in this case, the patient was doing well, and then went to the ICU and started deteriorating. Urine output dropped, they're on more inotropes and pressors, and the PA sat drops to 27.5%. The RA pressure goes up, and note the PA pressure doesn't go up, it sort of, went down. So what's happening here is this is not LV failure, this is not sepsis, this is actually just failure of the RV, and the RV needs to be supported. So in this particular case, the diagnosis was made because the swan was in, the echo was obtained, and the patient went back to the cath lab, had an Impella RP inserted, and immediately started making urine. The inotropes were decreased, and then this is the trend of the hemodynamics that happened immediately after insertion, where you see an augmentation in PA sat, augmentation in PA pressure, and when the RP was eventually removed a few days later, the numbers had all improved because the RV, as being a resilient structure, had recovered. So this is an important teaching point and involves the diagnosis of RV failure, specifically in this setting. It doesn't happen all the time, but if you're primed to it and you think about it, even in cases where there's LV failure, you might have RV failure occurring concurrently. Think about the RV and don't just ignore it and throw up your hands as to why the patient is getting more and more sick. The final couple slides I just wanted to show look at how we classify cardiogenic shock. We know about the SCAI classification, looking at this worsening prognosis over time. And the real question is, what device do we select when? And what you really want to start off with is exactly what Kendra said. What degree of support does the patient need? And what's the ultimate destination? How long do I need to keep it in for? What are the other comorbidities? And is the patient stable for transfer to the places? And when you can sort of answer those questions, you then know how to titrate the therapy to the patient, which is ultimately what we aim to do in clinical medicine. Now, there are complicated algorithms that are out there. There are simpler algorithms, but I think because we have complicated patients, the algorithms tend to be titrated. And I'm not going to go through this in detail. This is the algorithm we use at our hospital. But essentially, the questions we ask are, where is the support coming from? Is it RV? Is it LV? Is it biventricular? Or is it cardiac arrest? And based upon those questions, we will use any and all of the devices to help the patient get what they specifically need. And that's why the algorithm is complicated in this way, because we tend to think, we tend to apply what we need best, and that's how we aim to help our patients. So with that, that's an overview on RV support, our general principles for support as a whole. I'll get back to Kendra and ask some questions back and forth, and then we'll go on to the live cases. Thank you. All right, so let's first go to the poll results, so that'll help inform the discussion. So this is a poll about what cath labs need to have and need to do. Let's put that poll up and let's see what people answered first. So almost 90% patients say every cath lab should be able to install MCS. We didn't get into the details of what MCS they need to install and whether they're equipped to deal with it. Kendra is a surgeon who is not only used to doing all these things, but used to potentially bailing out from scary scenarios. Do you agree with that? Should every cath lab know how to do all these things, or does that make you a little worried?
It makes me a little worried because I think that you and I have the luxury of having every device on the shelf and having the volume to be still good at all of those devices. I mean, we collectively at our institutions. If you're at a smaller center where you're only seeing these types of patients every once in a while, what you need is something that you and your team can be proficient with, that can save the patient and provide end organ perfusion long enough to get them to the center where they're going to have definitive therapy.
Yeah, this hub and spoke model, I think it sounds self-serving, but the reality is a lot of hospitals that don't have not just the devices, but the full team and resources. This is labor intensive. This involves calls in the middle of the night with really sick patients. And this is not one where you sort of answer the call on the phone and then the patient gets dealt with. You're often at the bedside, your team's at the bedside. So I think exactly what you said, get them on some support and then often transfer is important. And that's also why it's important to know how to do it safely, because there are many transfers that come in with massive bleeding complications and other issues too, and that doesn't help the patient as well. Kendra, do you think, some of the principle I mentioned about this RV recovering relatively quickly, is that generally what you see? I mean, you see the whole spectrum of it. Are there times when you just know the RV is not going to recover? How do you make that decision to sort of go beyond the percutaneous options and perhaps do it more surgically?
So I think that we always hope that it's going to recover. We actually see it pretty frequently after post-op. And we do exactly what you've just described, decide whether or not the patient needs additional support. But we're going to wait a pretty long time with a percutaneous technique first to try to let the RV recover before we go on to something more invasive. So your algorithm is spot on with what we're doing as well. But I'm curious, how frequently are you having to use it at Columbia?
It's relatively rare. That series I showed is basically this series of post-LVAD patients, so that is kind of a scenario that we see. We don't have a ton of acute MI volume, specifically at Columbia, so, and even so, there are RVMIs where the patient looks shocky up front, but with pacing and reperfusion, the RV starts to recover relatively quickly. That principle I mentioned of watching the patient closely, potentially even keeping them in the cath lab, is one that applies, by the way, to the LV as well. We see sometimes that patients who are not sick enough to merit the support up front, once you reperfuse them, they sort of turn in one direction or another, and you know that relatively quickly. And so we tend to like to do the escalation while the patient's in the lab, whether that's RV support, whether it's ECMO, whatever it is. Maybe a brief word on ECMO. For us, it tends to be crash and burn type patients post-arrest, and then oxygenation issues where you think you need the oxygenator. Is that generally your take on it too, or are there other scenarios where you might think of doing ECMO?
No, I agree. I think that those are kind of where we end up using ECMO. It's the crash and burn. It's the patient that they've already exhausted all of their resources, and then we're being called. I do think that if we were able to kind of have a heart team for mechanical support, we may go to ECMO sooner in some cases as an adjunct to the devices that are already being used, not as an instead.
Yeah, that makes sense. And how about moving, because I think the cases are going to be high-risk PCI cases. From a surgical standpoint, how much support does a patient actually need during a high-risk PCI? Obviously, it depends on the anatomy a little bit, but do we really need 4 liters of support or something like that for a conventional, high-risk PCI, or do we think that lesser degrees of support might be okay?
I would have to throw that back to you because I don't do PCI anymore. But I think that probably lesser support is what will be needed. To have full support to do a very complex case. I don't do complex PCI, but I would assume that that's going to be more than what's needed for most of the complex cases.
Yeah, first of all, Kendra did do PCI, and so she doesn't do it now, but she knows fully well. So it's not just asking a random person or a random surgeon the question. She actually has a lot of knowledge on it. What I will say, though, is that typically speaking, the level of support is often dictated by the clinical syndrome, and that's one of the reasons why in shock we aim for deeper levels of support. High-risk PCI we might not need as much, and some would argue we don't need it at all for many cases. That's actually being randomized in the study Protect 4, which actually enrolled its first patient this week. These are patients that have a depressed EF. It goes up to 40, but basically randomized to Impella support versus standard of care, which could include balloon pump if needed. Really sorely needed trial because we just don't know the answer to this question at this time. For certain cases, you wouldn't think of doing them without support. There are other cases where honestly, in our lab, we'll do a right heart cath. The hemodynamics look pretty good. We feel pretty comfortable, and we try to spare the patient the risk of a vascular complication. So no way better than doing a randomized trial to sort that out. And this trial will certainly be garnering a lot of interest as it enrolls patients over the next several years. So I think with that, that, we're going to sort of wrap this session up and go on to the live cases. Two great cases from Nicholas and Holger. Hopefully Azim Latib will be able to join us for the panel discussion as well. But great quick hitting overview of large bore access, types of support, left side and right side, and kind of what to expect for clinicians going forward, not only in their own labs, but also from the standpoint of randomized trials.